Thank you all for being here. With the snowstorm and school cancellations, we know it's no easy feat to pull off. In 2026, one of our goals at Bloom is to engage more with our community and bring our clinical knowledge to those of you on the front lines. We understand how busy you are, and while there are times when it's really clear that testing is needed, with more subtle presentations, it can be challenging to know whether testing is necessary. Our goal today is to offer you some key points to have top of mind as you navigate these complex decisions. Together, we can shorten the time it takes for patients to get an accurate diagnosis and receive the treatment that they need. As you're listening today, if you think this content would be helpful for a colleague or you'd like to watch this webinar again, we will share a link of the recording in a couple of weeks. We'll also send you a key takeaways document with the highlights from this presentation, and feel free to share with anyone that you'd like. We chose to focus on ADHD, autism spectrum disorder, or ASD, and dyslexia because they're the most common diagnoses we're giving later than would be ideal. One reason they're often missed is that they share observable symptoms, even though the underlying mechanisms differ. For example, inattention may be caused by attention dysregulation in ADHD, sensory or social overload in ASD, or language-based processing strain in dyslexia. Comprehensive testing allows us to determine why someone is struggling and connect them with the right interventions. Prior to getting an accurate diagnosis, many of our patients participate in services that aren't addressing the root cause of their challenges. While early intervention leads to better outcomes, we can't properly intervene until we know what we're treating. Many of our testing patients spend months or even years with either no supports in place or the wrong supports. For example, a child struggling to learn to read may get nonspecific tutoring instead of specialized tutoring that's evidence-based, like Orton-Gillingham for dyslexia. Or a patient struggling socially may participate in therapy to address what was thought to be social anxiety, but turns out to be ASD. Later, we'll discuss the amount of negative feedback patients receive from the world around them while they're waiting to get an accurate diagnosis, feedback that really harms their self-esteem. Sometimes parents fear that getting a diagnosis will hurt their child's self-esteem, but it actually protects it. So often, the wait and see approach is encouraged. We hear from many parents who end up in our office that they were encouraged to give their kids time to grow and develop rather than pursuing testing. On the one hand, we totally understand that, especially in the age of helicopter parenting. Some parents are overly concerned about behaviors that are really developmentally appropriate, or they struggle to accept that their child is performing average or a little below average when they expected their child to excel. When those parents end up in our office and it becomes clear that testing is not appropriate, we connect them with other services like parent training and therapy. We also frequently see parents who were discouraged from pursuing testing, thus delaying diagnosis and intervention. We hope to be part of that shift from a reactive model to a proactive model by improving your ability to identify when it's time for testing. We'll discuss in detail what masking looks like in ADHD, ASD, and dyslexia later in our webinar. For now, let's start with an overview of what masking is. Masking is suppressing or disguising symptoms in an effort to meet expectations and fit in. Some patients are aware that they're masking and they're aware of the toll it takes. Others are not. Masking is particularly prevalent in high-achieving or gifted individuals who internalize their distress. It's also more common in girls and women. While masking may have some short-term benefits, in the long term, it leads to fatigue, burnout, anxiety, and delayed diagnosis. We have 4 goals for today's webinar. We'd like to improve your ability to recognize the subtle presentations of ADHD, ASD, and dyslexia, build your understanding of how masking and scaffolding hide difficulties, demonstrate why screening and observation often miss complex or subtle cases, and explain how comprehensive evaluations allow us to accurately diagnose even the most subtle presentations of ADHD, ASD, and dyslexia. Now I'll turn it over to Dr. Adriana Caballero, who will be discussing subtle signs of ADHD in depth.
Well, we'll begin our conversation about why ADHD is so often overlooked or even diagnosed late. And we're beginning here at what we like to call the scaffolding effect, or how parental support ends up masking deficits, even with the best intentions, of course. We know parents are always moving with the best intentions, but sometimes, as we'll see, it can hinder some of the deficits being kind of made aware. Standardized rating scales measure behavior in context, not capacity. So when parental support is really high, the child is functioning in essentially what we like to call a prosthetic environment. Their executive skills are being externally supplied, mostly by parents, but sometimes by teachers and even other peers, of course, with those best of intentions. A classic example that we tend to see is a child who scores in the average range on the home-based rating scales. And it's not because they have really strong executive functioning skills, but because the parent is really successful at preventing executive dysfunction or executive failure. Parents are providing constant reminders, they're setting up routines and making sure their kids walk through these routines step by step. The parents are making sure that the devices are charged at the end of the day, that you know exactly what's going to happen because they have a really nicely laid out hour by hour schedule that's put up somewhere conveniently in the home. The child's skills may look intact, but it's actually kind of being borrowed or supplemented from the parent. And this is often where we get fooled. The heavy scaffolding can artificially inflate real world success. The child's grades may look acceptable, the behavior reports are mixed or even normal. Rating scales can come back subclinical, but the child is still exhausted at the end of the day. The family's feeling overwhelmed by the level of support that they're providing, and everyone's kind of working harder than they really need to be. What testing does differently is that it removes the scaffolding. Testing shows us the optimal performance under really standardized conditions where the prosthetics from the environment are kind of stripped away. And that's often where the true deficits in attention, processing speed, working memory, language, and cognitive efficiency finally become visible. And this kind of brings us to our next layer that's kind of supplemental to that, which we like to call the surrogate frontal lobe. So children with executive function deficits continue to rely on external supports from their environment, most often the parents, far past the age of their neurotypical peers. Parents essentially become this child's external prefrontal cortex, actively managing kind of everything for the kid, or providing those reminders for them to, hey, do these things. While this co-regulation keeps the child functioning in the moment, it comes at a cost to the parent. And a lot of times, even the family. There's burnout, stress, and the invisibility of the labor involved often becomes too much. From a clinical perspective, the child appears really well behaved during the brief office visit to either their physician or maybe it's a quick therapy meeting, and referral sources may often miss the underlying struggle entirely just because of the surrogate frontal lobe support. And this support we see usually starts really early and it kind of never stops. It becomes normalized in the family. Parents don't realize it's no longer developmentally appropriate to remind a child multiple times a day to, hey, put on your socks or walk them through their everyday routine. it's acceptable, right, when they're 4 or 5 to kind of get them started on those routines, start that initiation. But eventually, as they get, 7, 8, 9, you want them to develop that skill independently. And often the moment of clarity comes when a younger sibling suddenly does these things independently, and the contrast becomes impossible to ignore. So when we see a child performing adequately, we have to ask ourselves, is this skill really theirs, or are they borrowing it from a parent, a teacher, or another environment? Psychological testing becomes critical because it allows us, again, to strip away these supports and observe the true unassisted performance. Next, we'll look at how this borrowed performance eventually starts to fail as the child gets older and the cognitive demands increase, and what signals tells us it's time for formal testing. And I just want to make an important point that a child that has a delay in executive functioning isn't behind in necessarily everything. Executive functioning affects skills like planning, organization, emotion regulation, but it does not limit intelligence or even talent. Many kids with executive functioning delays have high IQs. They do really well in school, sports, music, other crafts, or other arts areas, but they just need support with thinking and self-regulation that can't really go on into the teen years. And then we'll kind of dive in a little bit to what I like to call, and kind of what the ADHD field likes to call, the 30% rule. So, neuroimaging research shows us that children with ADHD often experience a delay in cortical maturation, especially in their prefrontal cortex. Um, Kind of the areas that we're talking about when we're talking about providing the scaffolding and the supplemental frontal lobe. This is the child's brain executive hub. And in other words, their brains are a little biologically behind their neurotypical peers. A child with ADHD or executive dysfunction, they have harder times self-regulating at about 30% younger than their actual age. If we're looking for a very concrete example, imagine a 12-year-old in sixth grade. Based on executive functioning, if we're going by this 30% rule, their brain may be operating at the level of an 8.5-year-old or roughly a third grader. You might be asking yourself, well, why does that really matter? Well, we set expectations based solely on chronological age. Within the school system and also at home and things like that as well. We're asking these kids to perform tasks their executive skills aren't ready for or aren't developed enough for. If supports are pulled too early, the child can experience what I call executive collapse. Suddenly, the routines break down, frustration spikes, learning can stall. So, for educators, therapists, parents, and even physicians, the key takeaway is to adjust expectations to the executive age and not the calendar age. It's not lowering the standards for these individuals, it's setting them realistically so children can succeed and create opportunities, even for bolstering these skills in therapy or even at school. They might be that 30% delay behind, but we can put other interventions in place to kind of bolster those skills. Next, we're going to take a look at how this plays out across multiple domains of functioning and why it matters when you're trying to decide if it's time for a full psychological evaluation. And an important piece of that is this emotion regulation piece. Emotion regulation is a core challenge for many individuals with ADHD, both children and adults. Emotion regulation is much more than just being moody. It's often tied to underlying executive function difficulties like impulse control, working memory, planning, and time management. And as we talked about, when a child is in a prosthetic environment or the parents are providing a lot of that external support, we can see kids being more emotionally dysregulated at the end of their days when they've used up all of their cognitive resources. Maybe the parents are close to using up all of theirs, and everybody's just getting a little bit more dysregulated. When we talk about the DSM-5 context, it doesn't explicitly list emotional dysregulation as a core ADHD symptom, but it acknowledges that it's commonly associated under both presentations, so both predominantly inattentive as well as the combined presentation of hyperactive, impulsive, and inattentive presentation. So while a patient could appear primarily anxious or perfectionistic, these behaviors may actually stem from underlying ADHD-related self-regulation challenges. And psychological testing, when you get a full evaluation, really pulls apart all those pieces for you. And this is important because behaviors can look like perfectionism, anxiety, and overachievement, and not to say that they can't co-occur together, but they can become easily misinterpreted. Without context, clinicians, teachers, other supervisors might assume the person is being, just emotionally dysregulated or overly controlling or conscientious, but they're missing some of these underlying ADHD related executive dysfunction. And our next slide, we're going to kind of understand a little bit more about how this might look with using a very common duck analogy. So if you can picture a little duck like the one in the photo who's, gently gliding along the stream, at the surface, right? He looks really calm. He's maybe even smiling a little bit, but underneath the surface or underneath the water, we can see him like really paddling those feet to stay moving. Well, this can be applied to individuals, both adults and kids with ADHD, in terms of a lot of times common scenarios we see are them over preparing, being hypervigilant. They're doing everything that they can to appear calm, collective, and put together on the surface, but underneath, they may be really struggling with some of that executive dysfunction. A common thing that we see in the office a lot of times is patients sharing that they arrive 30 minutes early for their appointments, but they wait in the parking lot. They want to make sure that they're on time because maybe time planning is not one of their strong suits, but they don't want to give the appearance that that's something that they struggle with. So they'll wait in the parking lot so no one has to know they're here 30 minutes early. They don't want others to see the chaos behind the scenes. In other extreme examples, this can extend to everyday life, arriving very early to work every day, sometimes at the expense of sleep, all to appear organized and control. Um, and it can just give you this duck picture can kind of give you that context of we don't always know what's going on underneath the surface. And so, from a clinical perspective, getting a full psychological evaluation kind of lets us take a peek under, what are all those heavy supports and what does it kind of look like when we kind of strip those away? I want to talk about now something that we see over and over again in our practice, which is kind of correlated to everything else we've been talking about, which is this negative feedback loop and why it's so devastating for children with untreated ADHD and even adults. So imagine a child navigating school and home and everyday life, and their world is filled with corrections. Sit still, focus. Why didn't you turn that in? You made all these careless errors. Research suggests that by age 10, a child with ADHD may have heard 20,000 more negative messages compared to their neurotypical peers. And this can kind of create what we call an internalized voice of shame. And so, to put it into perspective further, some experts note that for every positive comment that a child receives, they might get 10 to 50 more negative comments. And this is a kid with ADHD or maybe undiagnosed ADHD. So even when they try really hard, they're constantly being reminded of what they did wrong, not what they can do right. And again, this constant correction feeds into that kind of internalized shame as well as to learned helplessness. The child starts believing that they may be bad or stupid. There have been a lot of kids when I've been testing them, they'll say, well, how am I doing? I know I'm not really good at this, or I know I'm bad at school. They kind of internalize those messages and they'll even repeat it in their testing if they perceive that they've got something wrong or that they're doing something bad. And it's not a failure of character, it's often a mismatch between their brain and their environment. And this can have real world social consequences, not just on their self concept, but also in terms of peer rejection, isolation, and further self esteem lost. So, when we talk about testing and eventually intervention, it's not just about academics and attention. It's also about breaking this cycle of this negative feedback loop and the impacts that it'll have on your emotional well being before it becomes entrenched. This can also kind of gently lead us into what we call the first grade effect. So, kindergarten through first grade is a very critical window. Early academic engagement, strong student teacher relationships during this K through first grade strongly predict long-term academic and behavioral success. When the early experiences of kids struggling with executive dysfunction and ADHD are negative, especially in the K through 1 kind of area, their attitudes towards school can uh, solidify into a negative experience. Children begin to avoid academics. They say they hate school, they don't want to go to school, and by the time that concerns are addressed later, often they have this mindset of this isn't going to work, everything's kind of bad or negative, and it makes intervention a lot harder. Not impossible, but a lot harder. These ADHD symptoms, in terms of impulsivity, inconsistent performance, social challenges, they naturally draw more of that corrective feedback from adults, reinforcing the idea that school is a place where they're always in trouble or they're always doing something bad. And again, to reiterate, this is why early testing matters, not because there's something wrong with the child, but it's because it can change the entire trajectory of how a child relates to school, shifting from a more negative outlook to putting in proper accommodations and interventions and things like that to hopefully lead to a more positive experience. So, if early negative experiences can calcify a student's relationship with school, the next question you would ask yourself is, well, what happens when we wait too long to intervene? Well, we know that untreated ADHD rarely ever travels alone. Over time, we often see what's referred to as ADHD plus, or the emergence of these secondary psychiatric conditions, most commonly anxiety and depression, but also different specific learning disorders. These are not random, right? Anxiety develops as children become hyper aware of their forgetting, missing, or messing up. Depression can follow years of effort met with constant negative feedback. And in fact, early inattention trajectories strongly predict later internalizing symptoms like anxiety, depression, internalized shame. And early ADHD treatment can kind of mitigate or reduce that risk. To kind of go on our last slide as well, we also see this show up after school with emotion dysregulation. Children hold it in together all day. They know the expectations at school, and they use every ounce of coping they have to get through the day. And by the time that they get home, those resources are almost depleted, leading to emotional meltdowns, irritability, and exhaustion. This is why early testing isn't just about diagnosing ADHD, it's about preventing that cascades that often follows when the core issues kind of go unrecognized. And then to talk about late diagnosed adults and their coping strategies. So, this is not an isolated event that we see with kids, but we have a lot of adults that come into our office that are undiagnosed with ADHD or they're diagnosed later in life. And they report that they have developed, adaptive coping strategies that help them get through their work days, their home life. But it comes at a cost to their emotional well-being and their energy levels. Similar to the ones we've talked about previously, we have adults that are really over preparing. They're very perfectionistic. They avoid a lot of times challenging tasks because they know like they're struggling in those areas and maybe they don't have the skills to complete it or get through it appropriately. And these strategies can work in structured, low demand environments. But as we see when, kids grow up to teens and then adults, as demands increase at work, home, school, these coping strategies that they have often break down and they just don't work for them anymore. And this failure can lead to noticeable impairment and eventually prompt an ADHD diagnosis. So the key point of this would kind of be, well, what looks like functioning well in terms of an adult that's functioning well may actually be an adult that's really good at masking their struggles, or they have these adaptive coping strategies that they're using and using until the demands increase and they can't hide really as the chaos. And if we're thinking back to the duck analogy. So as, life gets more complex, these adaptive coping strategies aren't able to help individuals stay going through their day to day. I'm going to pass the torch over to Dr. Idell to tell us a little bit more about what masking in ASD, dyslexia, and ADHD kind of look like.
So I'm going to talk more about masking in all three of those conditions. And masking makes early identification of these disorders more challenging, which then leads to later referrals for the evaluation. Masking involves consciously and unconsciously hiding ADHD, autistic, and dyslexic symptoms in order to appear more typical in social, academic, and work settings. So some common masking behaviors in ADHD may be mimicking social cues, such as really focusing on maintaining eye contact, even though they may not be actually focused on what is being said in a conversation. The child or individual can look like they are paying attention, but their mind is elsewhere. Actively suppressing ADHD behaviors also can occur, and this can be exhausting for the individual as they are focused on trying not to do something and to control their impulses. Sometimes it's helpful to fidget with less obvious methods, and there are plenty of fidgets out there that have been designed to help with this. But in the end, the suppression of these behaviors is draining. And then individuals can also be very distracted by carefully monitoring their own body language and their facial expressions, which again is just detracting from what they can pay attention to. So some reasons for masking have been already touched upon, but really the pressure to conform to our society's expectations are a driving force, as well as the fear of judgment and the desire to avoid stigmas that are still out there associated with ADHD, such as being viewed as someone who has no control over oneself. This is particularly potent in the adolescent years and into adulthood. Individuals who have anxiety premorbidly are already more likely to engage in these masking behaviors, particularly kids in school, and it can often make it difficult for teachers and other adults to notice any kind of ADHD symptoms. Masking comes with an emotional toll, which includes a lot of emotional fatigue and then the secondary mental health challenges that Dr. Caballero mentioned, such as anxiety, self-doubt. And then clients often will report to us that they're exhausted at the end of the day and the workday, and then that impacts their home life, their family life, and there's no physical reason for their fatigue. It was all from masking. It can also cause feelings of disconnection from one's authentic self, which is particularly difficult for children and adolescents who are developing their identities. And while in general masking can help with the social acceptance in the short term, it often causes the long-term emotional strain and secondary problems, such as family conflicts. So masking in dyslexia, it is a similar concept of using compensatory strategies to hide or work around reading, spelling, and writing difficulties in order to meet the academic expectations. But it is somewhat different from ADHD and autism spectrum in the strategies that they use. Masking in dyslexia shares the feature of effortful adaptation under pressure, but with the emotional and physical consequences. But individuals with dyslexia may divert attention from their reading difficulties through behavioral methods, such as becoming like a class clown. They also can pick up on context and cues in reading materials, such as pictures, and can learn to guess at words based on what they look like. Often individuals with dyslexia will memorize even the shape of the words or the image of a whole word. Oftentimes parents will say that their child will work really hard at learning to read a word on one page and then on the next page not be able to read it again until they have gotten to the point that they have memorized what that word physically looks like. People with dyslexia will often avoid reading aloud, which may expose their difficulties, and they often will avoid any kind of timed reading tasks because it exposes the effort and the slowness that comes from that. They also tend to spend excessive time on written work in order to be more accurate and to ensure that their spelling and their language-based difficulties aren't obvious. So the cost of these strategies includes significantly increased effort, which again leads to that mental fatigue, slower task completion and processing speed, and the emotional tolls of anxiety, lower confidence, dislike of school, and that negative self-talk. In autism spectrum disorder, many individuals, particularly females and those with average or higher IQs, can develop very sophisticated compensatory strategies to hide their social deficits. Mimicking social cues is frequently a strategy that we see that can be highly effective, but is physically and emotionally exhausting for the individual. We have many examples of this as we do evaluate adults for autism spectrum, and they can reflect back and tell us that they would read books such as How to Win Friends and Influence People by Dale Carnegie multiple times, and then practice and apply those strategies to appear kind of normal socially to their peers. The use of conventional scripts is also an effective strategy often used. So, for example, an adult who, as a child, their parents encouraged them to read books on developing skills such as sales pitches and sales skills, and then would have him go house to house to practice these skills by promoting their own family landscaping business. This requires an incredible amount of time and effort and leads to autistic burnout, which I will pass on to our next slide.
Okay, thanks, Dr. Raydell, for sharing all of that with us. So, autistic burnout is caused by the cognitive load of constant masking. It's a state of profound exhaustion that results from the chronic stress caused by living in a world that wasn't designed for you. And it often leads to a significant decline in daily functioning. Symptoms include exhaustion, a decreased interest in things you used to enjoy, a decline in abilities like time management, planning, organization, and self care. Those with autistic burnout often demonstrate heightened sensory sensitivity to things like noise and light that leads to increased irritability and difficulty regulating emotions. Social withdrawal is commonly seen in autistic burnout, as are impairments in memory, decision making, and focus. Given how I've described the symptoms of autistic burnout, it's probably not surprising that individuals with ASD are at an elevated risk for depression and suicidality. Patients with mild ASD often don't show the disruptive behaviors that have become highly associated with ASD. And in fact, patients with mild ASD are often able to do things that decades ago we thought patients with ASD simply couldn't do. And certainly that some people, who don't do the continuing ed to keep up with this still think patients with ASD can't do. So patients with ASD often demonstrate good eye contact. I've had patients share that they count how many seconds they need to maintain eye contact, and then they track when they should resume it. When we think about restricted interests, we often think about esoteric interests, like a 10-year-old who knows every detail about the tanks in World War II, or a 4-year-old who's obsessed with ceiling fans or vacuum cleaners. But some individuals with ASD have restricted interests that look typical for their age and may even help them fit in with their peers, such as a girl who's obsessed with skincare and displays products all over her room, or a boy who can recite sports stats in great detail. Individuals with ASD can certainly have friends, though they often describe their friends and themselves as quirky or weird. When considering symptoms of mild ASD, it really helps to discuss how much effort socializing takes, the impact of changing routines, or how patients respond when they can't engage in their restricted interests. Here are some additional factors to keep in mind when considering mild ASD. While behavioral rigidity is a core feature of ASD, it's frequently masked in structured environments like school and shows up more clearly at home. Many children with mild ASD can read obvious emotions, but struggle to interpret subtle facial expressions, tone of voice, or sarcasm. They may sense something is off without knowing what it means, leading them to ask questions, often repetitively, or seek reassurance. We also see atypical peer preferences. Think younger children, adults, or peers who allow conversation or play to center around specific interests. Many struggle with theory of mind, which is the ability to recognize that others have their own beliefs, feelings, and intentions, thus allowing for perspective taking and empathy. When these patterns are persistent and occur across settings, comprehensive testing helps us understand whether ASD, ADHD, anxiety, social immaturity, or a combination is leading to the challenges that are observed. Having socially acceptable restricted interests is particularly prevalent in girls with ASD. They often work really hard to seem normal socially, copying what their peers do to blend in. The duck metaphor that Dr. Caballero shared earlier very much applies to ASD as well. A girl with ASD may seem to be fitting in with her peers and making friends, but it's taking a lot of effort and coming at a high cost. Girls with ASD may appear socially typical, but they often struggle with interpreting implicit social rules, sustaining friendships, and managing group dynamics. This is especially true as they get older and social dynamics become increasingly complex and nuanced. Because their challenges are less visible, girls with ASD are less likely to be referred for testing, resulting in underdiagnosis or late diagnosis. Masking differences to fit in often causes emotional distress and increases the risk of mental health issues. Many women only receive diagnoses in adolescence or adulthood. That delay in diagnosis has a negative impact on physical health. Living with undiagnosed ASD causes a state of chronic hyperarousal or fight or flight, which causes significant wear and tear on the body. Patients with ASD have higher rates of chronic physical conditions. The most prevalent conditions in youth with ASD are obesity, neurological disorders, anxiety, and ADHD. Adults with ASD are more likely to experience recurring health issues that can significantly impact quality of life, including GI issues like obesity, diabetes, high blood pressure, elevated rates of epilepsy, seizures, migraines, and autoimmune disorders. Sleep disorders are often very prevalent, often due to a low melatonin production. I'll now turn it over to Dr. Rydell, who will talk more about dyslexia.
So, dyslexia is a complex learning difference that primarily affects reading and language processing. It's not a reflection of intelligence or effort, but rather a neurological variation that influences how individuals process written and spoken language. Dyslexia can manifest in a variety of ways, including difficulties with deciphering words, spelling, and fluency. Understanding dyslexia is critical because early identification and intervention can have significant improvements on educational outcomes. We really strive to encourage identification of dyslexia prior to age 8 in order to have the most beneficial impact from interventions. Unfortunately, the condition of dyslexia is often misunderstood, which does lead to delayed support and unnecessary frustration for students and their parents. Educators and parents should recognize that dyslexia is lifelong, but with the appropriate strategies and evidence-based interventions and accommodations, individuals with dyslexia can thrive academically and professionally. So this presentation aims to shed light on some of the subtle markers and identification challenges to help ensure better awareness of dyslexia and the support systems. Early identification of dyslexia is critical for ensuring the timely interventions that I mentioned. However, in many schools, while dyslexia screening is generally mandated, the use of literacy screeners are used, such as the DIBLs, or the dynamic indicators of basic early literacy skills. While these are valuable tools for measuring overall reading performance, they weren't designed to screen specifically for dyslexia. So screeners like DIBLs primarily assess reading outcomes, such as oral reading fluency or accuracy, rather than the underlying language processes that characterize dyslexia. As a result, students may pass these screeners despite having significant phonological processing weaknesses, and others may be flagged simply due to limited instruction, language differences, or even attention. So this can lead to both false negatives, where students with dyslexia are missed, and false positives, where students are identified as at risk without actually having dyslexia. So tests developed specifically for identification of dyslexia, such as the ones that we use in our evaluations, they're time consuming and they're expensive, which leaves most schools unable to use these comprehensive tools and allows them or makes them more reliant on screeners. However, relying on broad literacy screeners as a proxy for dyslexia identification can delay the appropriate diagnosis. It can obscure the root cause of the reading difficulties, and it can limit access to those targeted evidence-based interventions. So evaluators must recognize that the limitations of general screeners are significant and move toward assessment practices that directly measure those core features of dyslexia. Okay, so now we'll discuss some of the more subtle signs of dyslexia that parents, teachers, and medical providers might notice, but may not recognize as a reason to follow up with a recommendation for an evaluation. So in the preschool years, these include delayed speech and pronunciation issues, difficulty with rhyming, challenges recognizing or naming letters, even when it's in their own name, and frequent word retrieval problems. So evaluating language as a component of a dyslexia evaluation is important, and it is often not a component of most screeners. And the early elementary years, so again, prior to age 8, which is our preferred target age for identifying dyslexia, we continue to see a persistent slow reading rate compared to their peers. And also more prevalently, we'll start to see significant spelling errors in their written work. However, students may also start some avoidance, such as avoiding reading heavy classes, and they may have reluctance to read aloud and inconsistent spelling of the same words. So difficulty with spelling a word on one page versus the page before when they spelled it correctly. Most commonly known difficulties do include the confusion of similar letters and sounds and struggling to remember sight words. And then we also have problems with writing, such as organizing the written work, of course, the spelling, and then taking much longer on homework than peers. And then on to adolescence and the later elementary years in adolescence, that persistent slow reading pace, and oftentimes parents and will say that their kids are taking way too long on their homework assignments, and the child or teenager will also feel exhaustion and frustration that their peers can get through work significantly faster than they themselves are getting through it. We continue to see the spelling errors in their written work, and then the avoidance, especially in high school when they have those elective opportunities. They will try to avoid more of the heavy reading-based classes, and then also they'll experience difficulty learning foreign languages. This often results in students struggling with those core classes that are required for graduation. We also can see inconsistent test performance where students will perform better on oral exams and struggle more on written exams. There is also a pronounced gap between listening comprehension and reading comprehension. So the child or adolescent who loved being read to when they were younger will continue to avoid reading on their own. And then in adulthood, dyslexia often shows up in less obvious ways, especially in those individuals who have developed strong coping strategies. So some common signs for adults include, again, continued slow or effortful reading, needing to reread text to fully understand it, continued difficulty with spelling, and particularly in unfamiliar or multisyllabic words. Adults may avoid reading for pleasure or feel fatigued after tasks that require heavy reading and writing. Adults may continue to mix up similar looking words. They may have trouble recalling specific words even when speaking or writing. And then they often have challenges with required tasks such as note taking and written organization in both school and in the workplace. Many adults with dyslexia are highly capable thinkers and problem solvers, but reading and writing tasks may take significantly more time and energy than expected. So dyslexia should be viewed as a continuum rather than a fixed category. It occurs across all intellectual levels, meaning that individuals with high cognitive abilities can still experience significant reading challenges. There are no clear cutoff points that separate dyslexic from non-dyslexic individuals. Instead, symptoms can vary in severity and impact, similar to ADHD and autism. This perspective is important because it highlights the need for that broader identification method involved in the comprehensive testing that considers several factors instead of relying on strict limits and cutoffs often used in screening measures. Recognizing dyslexia as a spectrum can help educators and clinicians also tailor those interventions to individual needs and ensure that students receive appropriate support regardless of where they fall on that continuum. So dyslexia can affect anyone, including children with high intelligence and strong verbal skills. These strengths actually can hide reading difficulties so that a child might appear very intelligent and seem smart, yet still struggle with those basic decoding skills, spelling, and reading fluency. So the early testing and support are really important to ensure that those individuals get the help they need, regardless of how capable they appear in other areas of school and life. So some identification challenges, particularly false negatives related to screening, is a very frequent issue that we see in a lot of our intakes where the child has passed many of the screeners and is identified as not at risk, but yet is continuing to struggle with reading. Current screening tools may miss subtle signs of dyslexia, resulting in false negatives or undetected reading difficulties. And despite these state-mandated screening programs, students who are identified as not at risk can later exhibit significant reading difficulties. These false negatives can be up to 30% of students, particularly minority students. These oversights then delay intervention and allow academic struggles to continue and get worse over time. So continuous monitoring and comprehensive evaluation are then essential to minimize these false negatives and ensure that all students get the support that they need. The response to intervention approach used by school systems can be very helpful for many students, but for these more subtle cases, it often delays that comprehensive evaluation and rarely includes the cognitive testing that we need for understanding of how they process information. This means that highly verbal or high ability students who are statistically average in their performance, this may be masking their real needs and they're missed. So being aware of early warning signs allows educators, pediatricians, and parents to advocate for additional testing when it's necessary. This brings us back to Dr. Caballero.
So as we wrap up, this brings us to the heart of today's message, which is screening is not the same as a full comprehensive evaluation or the same as understanding. Conditions like ADHD, ASD, dyslexia are all complex and often subtle. They require careful, multifaceted evaluations, not just to identify symptoms, but to understand these co-occurring challenges, developmental trajectories, and the functional impact. Screening tools are good as screening tools and they can flag concern, but on their own, oftentimes they may be insufficient for cases that are more subtle, like Dr. Rydell was just discussing. Standardized assessment, clinical judgment, and ongoing monitoring are often what allow us to see really that full picture. And most importantly, the diagnosis that can come from a full psychological evaluation is often a protective factor for a lot of students. It changes the narrative from I'm just dumb, I'm just bad at this, I'm broken, or I'm lazy to my brain just works a little differently. And now I have a roadmap to help me and get me where I need to go. With these accurate identification, it comes along with the appropriate accommodations, interventions, and environments where children can really succeed, both at home, if parents choose therapy, as well as like the reports that we give to the schools that really help give some of those recommendations. Testing isn't about labeling, it's about clarity, compassion, and help changing the outcomes for these students. Assessment is the map. Interventions are often the route, and without it, we're just kind of guessing, but with it, we know exactly where to go. And I know what you guys may be thinking. We've learned a lot of good, really information today, but we are just truly scratching the surface. We have upcoming office hours that we do every month, and I think there have been a couple people on our previous ones. I see some familiar faces. But we are going to be doing some really targeted office hours where in the fall, we're going to be doing one specifically for dyslexia, one for ASD, and one for ADHD, where we will go into much more depth about kind of early identification and when to test one topic at a time. We're also setting aside this time specifically for providers, teachers, physicians to ask questions, consult, connect with colleagues across disciplines, really in a collaborative, low pressure kind of space. So if you want to deepen your understanding of these information, or if you have any other questions, you can always hop on our office hours. You can scan the QR code on the flyer here or on the slide here to get instant access, or email info@bloomspsychologyservices.com. We have a recurring virtual newsletter that goes out that has all of our really good information in there as well. We will be sending the recording and our key takeaway document out to everyone today. But if you would like the slide deck, just email us at the email listed on the slide and we can provide that to you. I'm going to turn it back over to Tanya for any questions that may come from this.
Thank you so much for that informative and relevant presentation. We now have a few minutes for a Q&A with our psychologists at Bloom. We'll start with a few questions that have already been submitted. Feel free to add any additional questions in the chat and we'll do our best to address them as time permits. Dr. Caballero, how do we differentiate emotional dysregulation related to ADHD from anxiety or perfectionism, especially in high-functioning adults who appear very organized?
Yeah, I think this is a really good question, and it brings me back to thinking about the duck analogy, where we have these high-functioning adults who appear very organized. They appear that they've got everything, going for them and going well on top of the surface. We know in ADHD, emotion dysregulation is typically fast. It's situational. It can be tied to demands on attention and executive control. We will see frustration kind of spike when the system breaks down or the cognitive demands become too much, even in highly organized adults who rely on that effortful compensation. And then, in contrast, in anxiety and even that perfectionism, we see more anticipatory and kind of rule-driven distress that's centered around fears of mistakes, evaluation, or not evaluation, sorry, well, evaluation from like peers or others, or this loss of control. With comprehensive assessment, we really look at what's the developmental history looking like for this person. In particular, their response to structure, whether regulation improves when the cognitive load is reduced, which is something we see far more in individuals with ADHD.
Okay, thank you. Dr. Rydell, is there a downside to my child receiving a diagnosis of dyslexia?
There is always the concern from, on parents and from children about stigma. And this is something that we often talk through during our feedback sessions about how to address this and explain dyslexia to your child so that they can understand it and really be able to advocate for themselves and not internalize this as a negative, but as a part of who they are, as well as to give them the insight to build those strengths and coping strategies. So from a clinical standpoint, the potential for the negativity is there right upon diagnosis, but we do work with families to try and help mitigate that so that they do understand that this is a positive and that the positives are outweighing any potential negative from feeling like you're being labeled or that your child is being labeled.
Okay, thank you. Dr. Tarbox, can you provide more information about how to evaluate the social skills of a child with mild ASD?
Yes, that is a great question. So, in really mild ASD, those social challenges can be so subtle. One thing we look for is really black and white thinking, taking things literally. So, sarcasm and even jokes can be challenging. Um, they having a truly reciprocal conversation is often a struggle, and we'll see kids kind of check out, sometimes literally just leave when they're not interested in what's being discussed. Challenges with turn taking, reading body language and understanding facial expressions are really difficult as well.
Thank you. We did have one additional question come in here. It said, could you speak to what defiance may look like with ADHD and also balancing recognition of a diagnosis versus using a diagnosis as an excuse not to try?
Yeah, I saw Emily's question, and we'll have to make sure to email her too, because it looks like she's hopped off. Um, I think what often looks like defiance with ADHD is really more attributable to feeling overwhelmed. That emotional dysregulation, we know from brain imaging studies, kids and adults for that matter too with ADHD are quite literally feeling their emotions in a much stronger way than someone who's neurotypical. So what looks to someone else like an overreaction really is just them being overwhelmed. Um, what looks like age appropriate expectations when we calculate that individual's executive age, as Dr. Caballero talked us through. It may be that our expectations are off for that individual, and that's why they're pushing back. Um, we often have parents worry that their child is going to use a diagnosis as an excuse. I bet that comes up in almost every feedback session. Steph, do you want to speak to that, kind of how you talk parents through that?
So I often want and do encourage parents to work with a behavioral specialist to help them become more aware of, is this a child who is trying to avoid or be difficult, or is this generally something that they cannot do? And to really look for behavior patterns. Is this something that consistently a skill that seems maybe this is an underdeveloped skill for that child and not an excuse? So that recognition of behavior patterns and really starting to understand ADHD We provide a lot of psychoeducational resources in our reports for parents to make them more aware of what to expect and what kind of behaviors might be maybe a little bit more manipulative. But really having a behavior therapist and then having that education under your belt is the most helpful of the tools that I recommend to parents.
Okay, thank you all for your thoughtful questions and participation today. If you have any additional questions or would like to learn more about other services that Bloom provides, we'd like to invite you to attend our virtual office hours session on Wednesday, February 4th at 12 p.m. You can drop in for the full hour or just a portion to connect with our team. We'd also like to invite you to save the date for our next webinar, Executive Functioning Essentials, on Thursday, March 5th at 12 p.m. We'll be sharing insights on how executive functioning impacts a child's health, behavior, and academic success, and guidance on what to or when to refer, how to support parents, and how to build a unified support system for your patients, clients, and students. You can find details on both of these upcoming events on our website. The link is in the chat. Feel free to reach out to us with any questions or to learn more at info@bloompsychologyservices.com. Thanks again for joining us, and we hope to connect with you again soon.